So that's been a highly debated topic because so there were a couple of trials, for instance, like Swift Direct trial and Direct Safe and Mr. Clean No IV, Direct MT, a couple of randomized trials that have looked at whether additional IV thrombolysis is useful when added to endovascular thrombectomy, or whether endovascular thrombectomy alone is just as good as the combined treatment. Because, of course, there are side effects to IVT, and maybe it causes delays and it costs money. So there were a couple of reasons to look whether it's actually needed in the setting of endovascular thrombectomy. And I think putting all those trials together, there's a meta-analysis called IRIS. They've kind of found that we cannot be sure that EVT alone or thrombectomy alone is non-inferior compared to the combination treatment. And that's in some ways unfortunate, because I think it's a lot of patients, several thousand patients, and still we weren't able to answer that question. So we could neither prove that it's non-inferior, nor could we prove that it's superior. So we're kind of stuck. And imagine like the effect size between the two arms is very, very small. So it's a minuscule difference between the two arms, but still we could not prove non-inferiority. And if you imagine, it would have been the other way around, that we would have started with mechanical thrombectomy alone and then seen whether we would want to find out whether adding IV thrombolysis is good. Then probably we would have come to the conclusion, looking at the same data, that it's not worth adding IV thrombolysis. So it's kind of getting really, really hard to get rid of treatments in these days. And it's still not clear whether IV thrombolysis adds that much. I think the current kind of agreement is that we should keep it, because in some cases reperfusion cannot be achieved with EVT, or maybe it improves the distal microcirculation even after the clot has been removed. Maybe there are some microthrombi that IVT could help to dissolve. So those are all arguments for keeping intravenous thrombolysis. But I think it's become clear that we do have a problem when we want to scale back our treatment or see whether doing something less is okay, because the threshold there for us is really much higher than for adapting new treatments. So, yeah.